My name's Dr. Brent Kimball. I'm a neurosurgeon by training. I trained in Memphis, Tennessee, then did an orthopedic spine fellowship in Australia. My wife's from Denver. Love it here. That's kind of how I ended up here. This conversation that we're excited for you to be a part of is really about adding a new friend or a new relationship, a new surgical colleague into your procedure for anterior lumbar exposure, be it lumbar TDR or multi-level, single-level ALIF, whatever it is. I think there's a ton of value here, and we're hoping that just us going through some of the nuances of kind of where we started and what values we picked up from one another in this process, that maybe you'll be able to foster similar value out of your relationship with your current approach surgeons, or maybe even find a new one that is willing to have this conversation with you.
And I mean, in fairness, we've talked about this, but your experience in Australia was unique. I think that the practice environment's different there. You've got it's probably more commonplace, would you say, that spine surgeons are doing their own access? But you've talked kind of some about the dynamics different just within their own practices, training background, etc.
Yeah, so I'll make a brief comment on that. Uh, Whether it's Germany, elsewhere in Europe, or Australia, and obviously I'm not from there, but I've spent some time doing surgery there. I've seen that their training models quite different from ours. It's less subspecialized in the early days. And so it's hard to compare training and comfort level with the anterior lumbar approach between an American neurosurgeon or orthopedic surgeon to one that's grown up and trained outside, because they go through general surgery residencies and get comfortable with things that we don't have access to. And so there's a lot more behind it. So you can't really compare and say, hey, well, man, these guys are all doing their own exposures. Why am I not? It's really, they're bringing more experience and they're bringing more value from their early training. That being said, my experience is that not everybody is doing everything on their own in Europe or in Australia or Germany, right? So they do work with access surgeons, but what I also noticed is that compared to my exposure here in the United States, when I was trained here in anterior lumbar exposure, they work much more closely together. It's less of a, hey, I'm going to go grab a cup of coffee. Let me know when you're ready for me. It really isn't like that. They're really working more hand in hand, at least the experience that I had. And that kind of cued me for when I came here to Denver and really started my practice. I wanted to find that. And I did spend some time with a couple other vascular or general surgeons doing exposure. And ultimately, John and I, we kind of found this opportunity where we like-minded and both were looking to understand what each other was doing. And that, you know, rather than jumping in and just saying, hey, I'm going to do this the way everybody else has always done it, we kind of found a new way, and it's suited us well. And I think you'll get a lot of value by listening in on this conversation today.
And I think when you and I met, I made it to Denver via San Diego, military commitment, a lot of complex pelvic trauma. That was a lot of my early experience effectively in vascular mobilization, spine exposure, beyond what I got in training. And then I think when you and I met for the first time, we came to Colorado, I think at a similar time frame. And so we're both kind of in a position where we're starting our practices, kind of trying to get our feet under us. We're both kind of new at the facility, new Denver metro area, et cetera, et cetera. And I think, I was doing spine access, but the dynamic I was used to was much different too. It was much more technical, maybe a little more isolated in practice, where as an access surgeon, you kind of come in, you do your thing, you leave. Spine surgeon comes in, does their thing, leave, and you basically trade off. And I think something I took away very early on as we built our professional relationship was that collaborative sort of mindset. Coming into the operating room, both of us having skin in the game and both of us having a level of commitment to seeing the operation through. And I think that's probably been the most impactful thing on my career development, is kind of following that relationship through and then seeing it develop in other avenues of my practice as well.
Yeah, I think it is very difficult for surgeons who are used to being in charge and digesting, consuming all the risk, all the complexities, being responsible for every little step, and then having someone else jump in and participate in that, but also be kind of united in it at the same time. Uh, we did some access exposure in our trauma facility in Memphis where I trained. General surgery would come in, they do a big thoracotomy or for a lateral transthoracic approach, and there was never really a question. Hey, do you think we need to take 2 ribs or just one or how much? You just kind of show up, and so there was really no conversation happening at all. Uh, there are other examples of this lack of collaboration when surgeons try to work together. So I don't think it's unusual that we struggle with trying to develop this, but I've been fortunate to, I do think it's great that we've been able to kind of grow up together in this, and I wonder if other people have a similar relationship where they can, maximize the benefit of each specialty together.
Yeah, well, and this is another question that has come up a lot in our conversations we've had, but just how the sort of collaborative partnership, if you will, has ultimately affected patient selection, how you're indicating your anterior spine procedures. Do you feel like that's been influenced by having more of a collaborative relationship versus, hey, I think this can be done. Can you do it? Yes, guy shows up. Maybe he does it. Maybe he doesn't. How does that influence things for you?
I think it probably influences things differently than you might expect because I'm comfortable in this procedure, anterior lumbar, for the same reason that I'm comfortable with anterior cervical exposure, right? So it's not just having a conversation about it. It is literally me understanding every layer of the access, every layer of how am I going to get there, where are the complexities, where are the complications, and you can't just have somebody tell you that. You have to be in it. You have to have your fingers in there, your hands in the wound. You got to see how it's happening and also feel like you are comfortable moving the tissue and working with it as well. Even if we're doing it together, having the chance to be able to get in there and participate in it and you not feeling like, hey, get your hands out, this is my part. I would never do an ACDF or whatever anterior cervical approach without fully being comfortable with the whole thing. And I wouldn't do any other procedure, brain or spine or whatever it is, without that same sensation. So I want to have that here, but if you separate the two components to the procedure, you totally lose that. Yeah, we can talk about it, but it's not the same.
When we talk about that collaborative partnership, for us it really begins preoperatively, right? It's not like show up day of, maybe pop some films up and wing it. We're talking on what, an almost daily basis about patients, about the pitfalls from both of our perspectives, and trying to synthesize that before we walk into the OR.
Sure. And obviously that relationship matures over time. So my hope is that when you see one of my cases coming on the books, and I haven't talked to you, because we don't talk about every single case, because it's not necessary, but you also know what I'm thinking, that you've taught me what to look for, that I've gained an appreciation for the nuances, the complexities, and complications that can happen from the access and exposure, and I'm drilling those into the patient selection part, rather than saying, hey, shoot, this is my only option, or I only do anterior lumbar exposure, because that's wrong too, right? Or I only do anterior lumbar approach, right? I would consider myself an anterior column surgeon, okay? I see tremendous value in that. I think you can do things through the anterior column you can't do other ways, but until you understand as the spine surgeon, and we talked about this, that, adding a mesh hernia, inguinal hernia repair to a simple procedure or a patient that looks simple from a vascular standpoint, that's just one simple example. There are so many more, but keeping those things in mind and how that adds to the complexities. And when it's a little bit outside my box and I, one, want you to have, a personal risk assessment on it, and two, really get a full heads up then I'm going to shunt them to you and say, listen, you need to talk to John before we can even engage in this surgical plan, right? So I have a lot of confidence that you're going to be able to do it no matter what, but it's not about can we do it. It's should we do it? Is it the right thing to do it? And also, if we're choosing to do it, what risk are we accepting? How long is it going to take? Because it's going to take longer sometimes. They're not all built the same. Everybody knows that. And rather than me just sitting in the lounge sipping on coffee, wondering why it's taken so long, I'm invested. I know this case is going to take longer. If it's on a flip day, it should be positioned, number 4 or whatever, right? So all those things add up to, a happy, healthy day of surgery instead of a frustrating one little thing that falls off can make the whole day more complicated and more stressful for everybody. So, I like operating with you because I feel like we have more predictability, even if it is complicated sometimes.
What would you want me to know about what you do that you think is critically imperative to better access on my part?
So I think first thing that I want my approach surgeon to know, and you specifically, is that this anterior approach is really just one of 3 or 4 different approaches that I'm considering in fixing this person's spine. So this is one option. It's not the only option. If I'm talking about it, it's because it's a preferred option. That's number 1. Number 2 would be that for me to make this surgery as efficient, and efficiency, as we've talked about, is a lot of different little things, but efficiency, safe and successful from my standpoint, is achieving the structural movement of the disc, opening the disc, releasing the disc, taking down the PLL, whatever it is, but being able to get into that space without compromising my ability to see what I'm doing and feel what I'm doing. So if you've seen someone that is able to achieve a good and fast surgical result and make something look really easy, it's not always about their technique or how they scrape bone off, annulus off the end plate. It's really about how critical the access is to getting in and getting out with your instruments safely. So it makes 2 millimeters, 3 millimeters it's like a world of difference.
And in fairness, we go back and forth. I would say, at least from my perspective, our biggest friction point or tension point relates to size of the incision and how that impacts on exposure. And this is something that I think I'm constantly going back and forth just in my own little bubble. And I think this has been a tremendous value add to my understanding of anterior spine surgery, is collaborating together, being there together through the operation, seeing where in extras, sometimes it's 5 or 6 millimeters skin incision, could be the difference of a real struggle. I really think it boils down to that much. I mean, it's not necessarily inches. Occasionally it is, but in reality, does a 5-centimeter incision matter so significantly to improve patient outcome that a 6-centimeter incision that improves the overall ability for you to do your work would not have some overall benefit to the outcome? And I think that's something, in my feeling, it's something we should be constantly debating.
I consider myself a minimally invasive spine surgeon, so whatever that means to whoever it is different. But minimally invasive, whether it's through the tube, I've done it all, I do it all, and you may too, but for me, it's kind of boiled down to how much do I need, how much exposure do I need, how can I minimize the amount of tissue trauma getting there. It's not just about the size of the incision on the ACDF. Really, it's about how long was I retracting, all those things. Very similar in the lumbar spine. How long are you retracting on the vessels, the ureter or whatever it is. All those things play in to keeping something less invasive. And for me, the more and more I've grown in my anterior lumbar access, I would much rather have a wide incision, a wide funnel-like access point, if that's what it takes to get me a space where I can safely get my instruments in and out, where I'm not struggling to fit, a disc space spreader and a curette or a box curette or whatever it is at the same time. I want to just have access, because if I can't see what I'm doing, if I can't, when it starts bleeding or whatever, or retractor shifts or whatever it is, it makes things so much more difficult, and it's already taking a space. We're already very deep sometimes. I mean, even if it's a very shallow hole, it's still deeper than any other lumbar posterior spinal hole that, incision site that we're working through, and definitely in the neck. So we're already really far away, and, taking just a little bit more skin incision, I think I'm perfectly happy with that. I tend to think it's skin and soft tissue, and I'm not as worried about it. And I'm also not as worried about, we don't cut a lot of muscle on this anterior approach. So I find that it's minimally invasive no matter what. We're going retroperitoneal, we're not going transperitoneal. So the marginal benefit for me as a spine surgeon to having a smaller incision, although it looks nice and maybe some patients like it, I would much rather have a larger incision. It doesn't have to be large enough to get me the access safely. That's more important than anything. If I'm going to struggle from an incision size, I'd probably rather not do the approach.
I'm kind of glad you brought in the whole minimally invasive topic. I have my own beliefs about what defines minimally invasive in the access world. I think in the spine world, muscle sparing is right. It's a lot of that conversation discussion. There's absolute value in that. I think there's a balance, and it's finding that sweet spot. So I've almost kind of, in my mind, shifted my buzzwords away from minimally invasive to optimally invasive. Finding the optimal incision size, soft tissue mobilization, fascial release, all these things. It's finding the sweet spot so you're doing your operation cleanly, efficiently. Like you said, there's a downside to having retractors in for an hour or two. I mean, we know that. Common sense dictates it, but you can easily end up 2 hours into a case where you're still struggling to get access. We've all been there, and there's a real detriment to that patient. So without question, in that case, should the incision have been larger? Should the fascial incision have been larger? I guess, yeah.
This is going to shift the subject a little bit, but I've gone back to Australia, I've gone back to Germany since I've done my training. And the thing that's fascinating to me is how fast and how quick the combination of the spine and or access surgeon is going to transfer from retroperitoneal to even transperitoneal.
Right.
And that's a huge jump, which I can't even remember the last time we went transperitoneal, right? But optimal access, they're picking up more complex cases, expanding their indications, finding new ways to get what they want, rather than finding a reason not to do it. So if transperitoneal is the right approach at L1-2, below the renal artery, that's what we're going to do. And we might not even be thinking about doing that. But it really isn't, we can't fit everything. You can't do every lumbar spine decompression through a tube because it's not right, because it's not the right approach, because it's going to injure the facets, because it's going to take too long, because it's a redo, and it's probably not as safe, and all the above, right? Well, it's the same thing in the interlumbar exposure. If you're not having this conversation with your exposure surgeon, you're cutting yourself short on a lot of cases that you could be doing, and you're also setting yourself up for a lot of frustration when you show up for a surgery because you're not aware of what it's going to take.
I think you bring up some great points again about communication and collaboration and how that translates to maybe more realistic expectations. I think having that appreciation for the nuances that each other experiences really opens many more doors than it closes. Like you said, it's a lot about getting away from that sort of siloed practices mindset, and even siloed responsibilities, the traditional access and spine surgeon relationship we've talked about. And I think that shift in mindset, it really feeling a part of the entire care process, is almost probably protective in a sense, even as you start to talk about more complicated cases, management of complications, etc.
I think one thing that I want to comment on also is that, and I don't know what place this has in your mind as a surgeon, but when I was raised into doing anterior lumbar approaches in the States, it was almost like a separation of surgeries, but also a separation of liability. We're not going to get into the med mal component of it, but it really does all kind of tie together. When I see a complicated patient, I am aware of the risks intraoperatively, but also the post-op management issues as well. And so I don't like having a patient where I'm not aware or comfortable with the post-op precautions that we need to be taking and management, the things that can happen, not just day 1, day 2, but week 2, week 3, week 6, whatever it is, just being attuned to that rather than be like, hey, I don't really know what's going on. Follow up with my access surgeon. That's not really good medicine, and it's also not good risk management either. So understanding those nuances, it really starts with understanding the pathophysiology and the pathology around abnormal anatomy and all the things you did differently in one case versus another. And so just being attuned to that. If you weren't there for the access, if you weren't there for the decision-making process, and you just said, well, we're going to do an ALIF because I feel like an ALIF today, it doesn't really make sense, and it doesn't really pay off long term either.
Well, and I mean, I think that kind of segues into kind of the ultimate benefit of establishing this kind of this partnership relationship between spine and access, which is patient and realistically practice. I mean, they go hand in hand. Patients do well, practice does well. Patients do poorly. It's hard to argue that that's not going to catch up at some point in time. And like you said, it's all in the nuances that start from preoperative counseling, knowing your patient, understanding their pathology, all the dynamics that go into the operation itself, and then being aware of what can go wrong. I mean, it's nice to leave the operating room and everything goes well post-operatively, but that's not always the case. And I've heard it said many times over, but good medicine is good business. In fairness, we're all running small businesses to some degree, but at the end of the day, there's no substitute for doing what we do really well. It's common sense, but good medicine is good business. If you're getting high quality patient outcomes, I firmly believe your practice is going to grow. I mean, your reputation is going to be built on that realistically.
Yeah, I think it's safe to let the patient outcomes drive everything. Takeaways from this conversation, most critically from me, are that this relationship is vital to establishing an anterior lumbar practice. If you dabble in it, it's also vital. But my guess is if you start to develop a relationship, whatever you're doing right now, it's going to double, it's going to triple, you're going to do a lot more, which maybe that's what you want to do. And I'd be surprised if you didn't find more success and enjoy that part of the procedure. Everybody loves an ACDF. There's a reason. Everybody loves a good ALIF also, and there's a reason. They're very, very similar. So there's a lot more complexity associated with the anterior lumbar approach and a lot of stuff that you need help with. So I encourage you to reach out to your access surgeon, sit down with them, talk about it. It's going to take some stretching on both sides. We both had to stretch to make this work, but getting comfortable working together and sharing the patient is really what it's about.